This is SSN.
Story Studio Network.
I'm Tom Hoppe, and I'm your host of the Most Painful Podcast. On today's show, we're going to carry on with exploring the connection between mental health and chronic pain. Today on the show, we have Dr. Don Richardson, a psychiatrist who's working with veterans and also currently work on a research project on the connection between pain and mental health. Don, welcome to the show.
Welcome. Thank you so much.
It's great to have you on. So maybe you can start us off by telling us a bit about your background and the research that you're involved in with veterans.
I'm a psychiatrist and a clinician researcher, and I'm the scientific director of the McDonald Franklin OSI Research Center, which is a center dedicated to improving the mental health and well-being of veterans and their families, primarily through research.
I remember we met in Montreal and you were talking about the research project that you're working on and the connection between mental health and chronic pain. But I guess, towards OSI injuries. Is that correct? Or is it in general mental health and chronic pain connection?
Well, primarily closer to operational stress injuries. So examining what we commonly see both as a clinician but also on the research side is a significant amount of people who suffer from OSIs, especially like PTSD and major depression, also suffer from chronic pain.
And is it possible that when you say that, like chronic pain, can someone have chronic pain without an OSI or even a mental health condition, and can it come on at a later time? We know chronic pain can be very debilitating. Could that, affect a person's mental state and then have issues with mental health or OSI, or is it usually OSI and then chronic pain?
Yeah, I think that's a very, very good question. So depending on where they start off in their recovery journey. So there are individuals, for example, I'm a psychiatrist, so people that come to see me most likely have a mental health condition. So if we're speaking in the veteran space, primarily PTSD and major depression are probably the top two. And of those, up to a third would also be suffering from chronic pain. Often the chronic pain is related, it might be directly related to an event that occurred during their service. So if we're looking at while they were deployed, it could be part of a blast injury or injury that occurred similar to what would occur here if they were done in training, like an accident or a physical injury. And from the mental health perspective, they might be reliving the events. And where the connection often occurs is that, for example, when they get triggered by pain, that memory is also triggering also the event that might be contributing to PTSD. So, for example, if they were physically injured, you can imagine if somebody was injured because they landed on from a landmine and they had quite severe injuries. That physical injury, every time that gets worse, it will trigger memories and will worsen their symptoms of PTSD and also depression. And if their symptoms of PTSD get worse, that they're getting triggered, it might also worsen their symptoms of chronic pain. This is from the mental health side. What I see from a lot of my colleagues who are working in chronic pain clinics, they're seeing things from a different perspective, meaning individuals will go to seek help and support for chronic pain. So almost everybody they see obviously have chronic pain, and a certain proportion of them will also have PTSD and major depression. And their focus has been on the chronic pain, but as they treat their symptoms of chronic pain, they've also noticed that their symptoms of depression and PTSD might get better. So it depends on which part you're actually looking at, and what we're trying to do not only on the clinical side, but on the research side, is to improve that collaboration, because they're often the same veteran coming to see me, and I'm focusing on one, and then in the chronic pain sector, they're focusing on the chronic pain and hoping that their PTSD or depression would get better.
So it has to be a coordinated approach in a sense.
Yeah, absolutely. That would be ideal. Yes.
Yeah. And is your research showing any difference between veterans and the civilian population when it comes to, I guess, chronic pain and the connection between depression or PTSD, or are you finding in your experience there's really not much difference between the two, between civilians and veterans?
That's a very, very good question that you're raising that we haven't looked at specifically in the chronic pain lecture. One, in that specifically, we are examining the potential impact or the use of ketamine to treat chronic pain, and also looking at its potential benefit for depression and PTSD. So that's one area. And most of the research that when we look at the at PTSD specifically is that military related PTSD does not respond as well to medication or talking therapy, the psychotherapy, when compared to civilian PTSD. And nobody really knows the exact reason why. We're looking at some of those that might be related to the severity of the symptoms, because military related PTSD tends to be more severe than civilians. It might be related to veterans are often exposed to multiple traumatic events rather than a single incident trauma that is also very common on the civilian side. And also in the military context, there might be differences with regards to the area of gender, meaning, or sex specifically, meaning that in the military context, the majority are men, while on the civilian side, individuals who have PTSD are more either 50-50 or more women are seeking treatment. So there are slight differences that we still do not completely understand why veterans do not respond as well. In the civilian side, when I speak to my colleagues in the chronic pain, they've also noticed that individuals who have chronic pain and they are veterans are not responding as well compared to the civilian side. That might have to do with the same thing. It might be that the injuries are more severe, and by the time they actually access services, if they're a veteran, they're years later. These aren't people coming out of still kind of in service. So those are really good questions that we need to do a lot more work to understand why, and are there different approaches, or do we need to approach kind of that veteran or military chronic pain differently than others?
So I want to back up a little bit where you said that veterans don't respond to the same kind of treatments, and hopefully I can articulate this correctly, but how do they not respond? Like what is it? Do they take longer to recover? Is the medication not working? Are they still being, anxious? Are they like, what is it that they are not responding to versus the other group?
That is such a key question that we're trying to come up with why they're not responding. So when we say they're not responding as well as when we do clinical trials, for example, we expect a certain number of people to respond. And when we compare a group of veterans who do the exact same treatment as civilians who receive the same treatment. So if for example we have a group of veterans and we prescribe them, for example, sertraline, an antidepressant, and we have a group of civilians who have PTSD and we prescribe them sertraline, the same med, veterans won't respond as well. And it's the same if we do prolonged exposure, different types of psychotherapies. In general, they don't respond as well, which is different than predicting an individual response. It means that many veterans who receive treatment do very well, but as a group, they don't respond as well.
And I wonder, I know in our past show we talked about military identity and mindset, and I've seen it myself when I've observed some of the family programs that have been going on where military identity and mindset, I wonder if that could be the difference, because I think you look at police officers and other first responders, they're constantly exposed to trauma over time as well. But, you just raise a lot of interesting points on why it would be different for veterans with OSI than, say, a police officer who's exposed to many things. And I just think back to our past podcasts is one thing that is different between the two is the mindset and the culture. The changes a soldier goes through, you know.
Well, absolutely. I think there's many areas that haven't been examined, and that might be one of the areas is identity and also areas of trust, meaning that for a lot of veterans, or if you look at military culture, they might have been socialized that they're the ones that are trained to take care of us civilians. And now when they become a civilian and they're seeking help, they now have to seek help among the civilians, like myself, a civilian. And so there is a whole area of trust that has an impact on whether or not you as a veteran, the general you, like, are you going to trust me that what I'm recommending is actually going to be helpful? And we also know that the therapeutic relationship is one of the key predictors of response for talking therapy. That means that that level of trust or engagement is so important. So sometimes we underplay that we're prescribing a pill and trust is not important, but there's some evidence that I think that would point that yes, that is trusting your psychiatrist or your family doctor also is an important role, because we know that even medication has a high placebo response.
Yeah, that's interesting because it makes me think back to a story of a veteran who both chronic pain and had some OSI issues and was doing fairly well and was put into a competitive space. He had to complete a task. It was a program. He was put in a competitive space, and he just automatically went back to that military mindset, started ordering people around without even knowing it, like it was breathing air. One wonders if it's become so natural to an individual to live in that space that does it impact them, how they act, how they see the world, how they view the world without even knowing it, without being aware? And does that impact treatment? Because we know in some of the pain clinics that we've heard from and from veterans and is because of mission first, self last, we become numb to pain. We just push through. So that's an example, right? So if someone in the military, for example, if you're late, it has a severe consequence. I'm guilty of that too. My wife gives me grief all the time when I say, hey, we got to be 15 minutes early, or I start getting antsy because it's just been inbred for many years that if you're late, you're going to be in trouble. But once one has awareness to that, it seems to, you kind of learn that you can work around it. But I'm just wondering if that whole mindset piece, plays into this too, right?
Absolutely. And even when you're sharing that, I can imagine that one of the treatments, especially in chronic pain, is pacing. Telling somebody to do,
Yeah.
okay, I want you to do this amount. But if you're trained that you can't actually do a task at 80%, that you're used to doing at 100, 110%, but now I'm asking you as part of your recovery, you're going to need to pace yourself and just manage those expectations to maybe like 60%. But then they go out and they do 110%, and then they're so sore that now they have to they're two steps backwards, because now they're on the either taking pain meds or they have to have a relapse, and now they're kind of lying on the couch because they overdid it. And so we need to adopt to that culture when they're seeking treatments, to say, when you're providing these little examples of things you do, that you have to kind of know the culture where it came from, because if you're asking somebody to do 60%, they might be doing 100. So you might have to really have that conversation so you're both at the same, my expectations are the same. And I really love that other example you gave for being on time, because a lot of clinicians don't start on time. And I wonder, from the veteran perspective, is that interpreted as disrespectful? And that could have an impact on building a trusting relationship.
Well, 100%. I mean, when you talk about pacing, when someone told me pacing, I thought they were going to run beside me. You're right with that. That's a good point too, because in Change Pain here in Vancouver, we did a little coaching program for veterans coming in between the coach and the doctor to kind of bridge that. Because as you know, going into a pain clinic could have high anxiety. It's a fast-paced place. And one of the things we did talk about was time. And we just let the veterans know that because of, situations the clinician may not be on time. Just don't worry about it. But you're right. If we don't make that acknowledgement, they may not. If it's been bred into them that you start on time all the time, they do get frustrated. No, there's lots to unpack here. So the research that you're doing now, is that the intent is to kind of just nail down some of these nuances between the veterans and chronic pain, and what are some of the stumbling blocks to recovery is between OSI and pain?
Yeah, we're trying to kind of look at all areas. So there's an area that we're quite interested in is on staging OSI, specifically staging PTSD. When we say staging specifically, we're saying that individuals that have PTSD and nothing else might be quite different than a veteran I'm seeing that has PTSD and chronic pain. They might also have sleep apnea, and they might have developed diabetes. That might be a different type of PTSD than somebody that just has PTSD and nothing else. So what we want to do is gather as much data from the clinical side and trying to tease that out to say, is staging helpful with regards to not only deciding what type of treatment and personalizing the treatment, but also managing expectations in the same way that if you came in and you had diabetes because your blood sugar was elevated, but if you had diabetes, but you also had high blood pressure and you also had problems because you can't feel your toes, that's an indication that you have peripheral vascular disease, small, and might be also affecting your eyes. Weight loss and diet might not be enough for you because you now have diabetes with other things, complicating factors, and we might need to be much more aggressive and say, okay, in your case, based on your signs and symptoms, you're probably we need to get your sugar down. You might need insulin. We might need to get you into a better diet. You might need to see one of my colleagues to make sure that your cholesterol is all. It's a completely different type of treatment. And one of the challenges I think we have with PTSD, for example, is that we treat everybody who has PTSD as the same, but it might be that some of these comorbidities are a different type of disease because and they might warrant different treatments. And how can we better manage and also manage expectation to say, well, based on the signs and symptoms, I don't think talking therapy is going to do it for you. You might need medication, talking therapy, but you might also need, you might need to go see my colleagues to get ketamine or for chronic pain, or you might need other types of treatments. So kind of jumping to kind of second and third line rather than just doing, one type of treatment, and also managing those expectations that we might have from both the veteran and their families to say, okay, well, based on their presenting, I don't see any reason why this person can't fully recover, or, based on what the person's presenting, I think this person should be able to get to, like 50%, but they're not going to be where they were. So I think that's kind of globally the research is to better personalize treatment, but also manage expectations so we can have that shared understanding of what I would recommend or what the research shows would optimize your recovery. But ultimately, it's the veteran's kind of decision on what they feel is acceptable to them. But at least we're not kind of throwing darts, kind of in the dark, kind of saying, okay, let's try this, and 6 months later, we're not any further ahead.
Yeah. So, I mean, I think the key what I got out of that too was building expectations, and then also education, which is what part of this podcast is, to educate people on what some of the methods and treatments and research is out there so that they can make an informed decision as well. So I guess at the end of the day, if we're not looking after mental health, chronic pain suffers. We're not looking after chronic pain, mental health suffers. So like you said, it has to be a coordinated approach between the two.
Yeah, and I think from my perspective, what we found in one of our research that chronicity of illness was not a predictor of recovery. And we were quite surprised on that,
Hmm.
meaning people who came and saw us and had PTSD from a few years to some who had 15, 20 years, they did not, they could recover just as well as others. So it wasn't a predictor, which we're kind of surprised. We thought people had PTSD longer would be less likely to recover. So there's something else at play rather than just length. So now we're starting to look, is it comorbidity that's actually making the difference? Is it other things? Maybe, as you mentioned, it's, maybe we're not doing a good enough job to measure trust or identity issues. Maybe there's other social factors that are probably have a greater influence than just how long you've had PTSD.
Well, I look forward to the results on the research, and I'm sure we'll have you back to talk about it when you got it all done. Well, thanks for your time on the show, Don. It was very informative. Hopefully, we'll have you back in the future to talk about it.
Okay, well, thank you so much.
No worries. So, for our audience, the next show we're going to be talking about will be mindfulness and chronic pain. If you have any feedback about the show or you want more information on chronic pain, you can visit our website at veteranschronicpain.ca or follow us on Facebook and Twitter at Chronic Pain COE and on Instagram at Chronic Pain_COE. Once again, Don, thanks very much for being on the show, and to our audience, stay well and keep the hope alive. Thank you.
The Most Painful Podcast is produced for the Chronic Pain Center of Excellence by Story Studio Network and Eye Contact Productions.